welcome everybody. Thank you for joining us again in this webinar series organized by Medtronic. And before I start, I want to thank the team of Maite for organizing and for supporting this great series. Today's subject is the management of advanced colorectal cancer disease. So we started this educational series exactly a year ago, and we started with basic laparoscopic skills, and we made a series of 12 modules on with increasing complexity with different colorectal procedures. So we started with basic laparoscopic skills, did right and left colectomy, and we ended up with rectal cancer surgery with transanal TME, APR, and exenteration. And we were very fortunate that we can start with season 2 today. And we will have 5 more modules on IBD surgery, endometriosis, pelvic floor disorders, and we end up in October with ERAS protocol and fast-tracked rehabilitation. So today we start up with the management of advanced colorectal cancer disease. And we have a great faculty. My co-chair today is Walter Brunner. And we organized this with the three of us. In another modules, you will find or see Andreas Chamillet, who I see in the background as well. So welcome, Andreas. And we have a great list of speakers today. Ian Jenkins from St. Mark's Hospital in the UK. We have Fernando Rotaler from the University in Navarra in Spain. And we have the well-known Brennan Moran from Basingstoke, UK, who will speak on the different subjects. I also want to have your attention for the next webinar already, which is in 2 weeks, which is going to be on IBD surgery. And then Andreas is going to be there, Walter is going to be there again, and we have great speakers, Stefan Brandt from Switzerland, Friedrich Herbst from Austria, and Willem Bellman from the Netherlands. Maite will send a registration link in the chats below, and in the chats you can also find a link to all the previous webinars, which you can find on YouTube as well. So we're going to start today, and we're going to start with Ian's lecture on the management of advanced colorectal cancer disease.
Ladies and gentlemen, good afternoon. I'm delighted to have been invited again to speak to you as part of this colorectal webinar series, and I'm thankful to both Colin and Walter for their introduction. I've been asked to talk to you as part of this session on the management of advanced colorectal cancer. Now, that is a fairly large topic, and as an intro to the session, I've had to think about how I might pitch this without treading on the toes of my colleagues Fernando and Brendan, who will be talking to you about not only minimally invasive liver surgery, but also management of colorectal peritoneal metastasis. I have no conflicts of interest. So what do we mean by advanced disease? Well, I think it'll be pretty clear what we mean by metastatic disease, and Brendan and Fernando will elaborate upon that later. But what do we mean by locally advanced rectal cancer? And this has been my area of interest. But what does that really mean? Is this locally advanced disease? You can see this huge mucinous tumor filling the pelvis. Is it this, where there's tumor extruding down through the perineum, involving all the anterior and indeed some of the posterior structures within the pelvis, as you can see in more detail in this picture? Or is it this, where there's disease extending anteriorly and indeed involving the bone of the inferior pubic ramus and ischium? Or indeed this cork in a bottle filling this poor patient's entire pelvis, which you can see in the axial images as well? Or is it this? Is this locally advanced disease? You can see the arrows pointing out in more detail these are rectal lymph nodes. Does this represent locally advanced disease? Or what about this? You can see there's a node within the pelvic sidewall. Is that locally advanced disease? And should we be talking about that? What about this tumor invasion of the blood vessels adjacent to or within the mesorectum? Is that locally advanced disease? Should we treat that differently? And what about this disease where there is tumour extending anteriorly to meet the seminal vesicles at the front or the mesorectum? Is that locally advanced disease? Or what about this? Is this locally advanced disease post-treatment when there is an apparent complete radiological response? The problem is we're not clear exactly what that means, locally advanced disease. Now, I've already spoken to you about exenterative surgery and abdominoperitoneal excision, and I've been contemplating where to go with this talk today in relation to advanced and locally advanced disease. I don't want to tread in Brendan or Fernando's toes, so I'm going to think about what we might do with locally advanced disease that might not require an exenterative procedure, and kind of broadly consider what the options for discussion in this area might be. Well, we're going to talk about locally advanced rectal cancer, but what about how that overlaps with neoadjuvant therapy? What about this watch and wait thing in terms of a locally advanced disease? I mentioned earlier about lateral pelvic lymph nodes. How might we address those, and what's the evidence there? And should we be doing this open, laparoscopically, or with robotics in terms of managing such disease? Of course, if there is a response to neoadjuvant therapy and it's not suitable for a watch and wait strategy, can we consider other options like a local excision of apparently either early disease or responsive disease to neoadjuvant therapy? And what does this do to a patient? What are the functional outcomes? There are other areas that we might consider in terms of adjuvant strategies, how we prepare patients up for surgery, and colonic cancer. What should we be doing with that? What about CME, for example? What role does that have in managing locally advanced colonic cancer? And of course, to do this, we have to consider what the evidence is, what trials there are, is there any guidance that might be relevant? And I'd like to touch on the controversies in all of these areas within the time that we have. So what might that be? Well, I might concentrate on some of the neoadjuvant strategies, what the evidence might be, as you will see in this slide, what watch and wait that results might actually do. Are there any local excision options like CARTS, TREK, Star Trek, GREC-R2 that we can discuss? Some of the functional aspects are worthy of touching on. And we'll think about some of the pelvic sidewall nodal issues that are out there. So this slide summarizes some of the major time points in the neoadjuvant story. As you can see, Bill Heald and the Basingstoke guys revolutionized how we look at rectal cancer management in terms of the surgery. 10 years or so after that, we saw with the Swedish rectal cancer trial the importance of neoadjuvant short course radiotherapy. The Dutch followed with the Dutch TME trial, showing its superiority with in the setting of a total mesorectal excision. And also we saw with the German rectal cancer study that preoperative chemoradiotherapy was better for local control than postoperative. We saw that adjuvant chemotherapy probably doesn't alter outcomes that much after chemoradiotherapy, and neoadjuvant chemoradiotherapy does not increase survival nor local control in the Polish trial. The importance of MRI became increasingly identified through the Mercury trial, again through our Basingstoke colleagues, and the MRC CR07 trial indicated that short course radiotherapy can improve local control and disease-free survival compared to postoperative treatment. Thereafter, we've looked at the role of oxaliplatin and relation to outcome. And in the last few years, we've seen the development of a strategy, let me go back to that, of watch and wait, which I'll elaborate on a bit further. We've seen the importance of short course, long wait with the Stockholm 3 trial. And more recently, we've seen studies looking at what has been described as total neoadjuvant therapy. And I want to touch on some of these areas because I think they're of current relevance. Now, this slide for the mid to late noughties from the UK shows just how variable the radiotherapy use has been across the UK. And we can look at that in a little relation to that later. But it does seem that there is a role for a highly selective approach to radiotherapy, which we can discuss later. Let's talk through total neoadjuvant therapy first, which is the most recent aspect of neoadjuvant strategy for locally advanced rectal cancer. There's two European trials. There's Rapido, which was reported recently, looking at T4A or EMVI or N2 or CRM positive disease or lateral lymph node disease, short course radiotherapy, 6 cycles KPOX or 9 of FOLFOX, then surgery or chemoradiotherapy, then surgery, then adjuvant chemotherapy, either 8 or 12, depending on the local adjuvant regime. They looked at 3-year disease-related treatment failure, a new outcome. And then there's a French Prodige 23, T3, T4, M0, FOLFIRINOX, then chemoradiotherapy, then surgery, versus chemoradiotherapy, then surgery, then adjuvant chemotherapy. Looking again, 3-year disease survival. And that seemed to improve the disease-related treatment failure and disease-free survival, and indeed many other outcomes, including the pathological complete response rate. So there does seem to be an improving and evolving role for neoadjuvant total neoadjuvant therapy. But there are, of course, flaws, and this is a letter to the editor relating to the Rapido trial. It's interesting that the outcome was changed during the process of the study, and this author proposed that the reader is left with the impression that the changes were made to fit with the already known trial results. Make of that what you will. And then we go to America, and OPRA, which seems very appropriate for the States. And it's the first trial that looks at watch and wait after a total neoadjuvant approach. And it shows upfront chemoradiotherapy, followed by consolidation chemotherapy, resulted in a numerically higher watch and wait rate compared to induction chemotherapy followed by chemoradiotherapy. All very interesting stuff. So let's think about watch and wait. Well, what do we know about this area? We know that TME with neoadjuvant chemoradiotherapy in most healthcare systems is regarded as the gold standard. Our Brazilian colleagues were the first to report this, testing the watch and wait approach to their management. They identified a subgroup with an apparent complete clinical response and then compared that with a cohort over nearly 5 years, where they found that both overall and disease-free survival were no different in the presence of a pathological complete response compared to a policy of active observation with intervention where the disease returned or there was regrowth. Of course, data registries have offered a chance of collaborative validation of the approach with some very encouraging results, that has to be said. But what is clear is that response rates are variable and a significant number of patients still regrow. But what is reassuring is that comparing surgery with watch and wait at 3 years finds the metastasis risk to be fairly similar and not statistically significant. And there's a few other data points to consider. This looks at the local regrowth rates, with most occurring within the first 2 years. And this seems to be dependent upon the clinical T stage, with a hazard ratio of 1.5 for each increase or incremental increase in the incremental increase in the clinical T stage. Now, it sounds awesome. We've eradicated surgery as well as cancer, it seems. But things aren't as they seem. It's really difficult to figure out how a complete response actually looks if there's little or no correlation between the clinical endoscopic or radiological examinations and pathological complete response. There's a heterogeneity in responders, with many seemingly having mostly fibrotic tissue with a low concentration of tumour cells. And sadly, the only way of picking that up is taking a large chunk of tissue for histology. And this may be reflected in subsequent local recurrences after chemoradiotherapy. The Mercury data in the UK showed both MRI and pathological TRG after chemoradiotherapy have prognostic relevance individually, but actually do not agree well. An MR-TRG is not a surrogate for pathological TRG. I've also some concerns when I read the watch and wait literature around the data quality and the distinct lack of prospective data collection. Pretty much all the studies are retrospective. Most of the studies are of small numbers and of patients, and hence the risk of bias needs to be really carefully considered. And when you unpick the study methodologies, I must say there is no standardization of multiple areas. These include patient selection, what neoadjuvant regimen is used, how the clinical response is diagnosed, how local recurrence and local regrowth are defined, and how patients are ultimately followed up, and what modalities are used for disease surveillance. Another area of contention relates to what happens to patients after they regrow and undergo salvage surgery. And again, the numbers of salvage procedure in the literature is low. It does seem that many actually are salvaged with a complete resection of 80 to 90%, depending on what you read, and that's deemed acceptable by most authors. Sadly, a reasonable number of patients will need salvage surgery, around a third or so. But the current evidence suggests that local recurrences may be higher after salvage surgery than with simply straight to upfront surgery. So it's unclear if survival is disadvantaged. But like before, the small numbers mean that we should be cautious with our interpretations. In addition, we have no idea on the morbidity of salvage and no idea on what the functional results truly are. Also, I see some conflicting ideologies with patient treatment. Most patients that have been treated with locally advanced rectal cancers are patients that have had locally advanced cancers and have been treated, and when to defer or operate was inconsistent. Some have suggested treating more earlier stage lesions with chemoradiotherapy and the assertion that higher complete clinical response rates are evident with earlier disease. But the real issue is that we have no idea who is likely to respond and who is highly unlikely to respond, and therefore we need that before any of the treatment starts. And someone is still to tell me what the number needed to treat is. This might only be of utility in a minority of rectal cancer patients, and actually more may suffer in the process of trying to obtain an otherwise elusive complete clinical response. Is the juice worth the squeeze, as they would say? And the rule of thumb that I have is that about a third respond, a third will regrow, but 90% will be salvaged successfully. And I kind of think of it in these terms. Of course, it's much more nuanced than all of this. Now that's for a complete response after neoadjuvant therapy. What about an incomplete but good response? Well, the French have produced a multitude of studies or GRECAR studies, and GRECAR 2 looked at local excision after a good but incomplete response after chemoradiotherapy. I'll show you some of the data there. Local excision versus TME, and TME was based on the estimated nodal disease risk. And interestingly, there was no benefit between either arm. Completion TME was not required in a lot of these patients, however, but the conclusion was it failed to show superiority of local excision over TME. Let's consider this concept of local excision after neoadjuvant therapy a little further. There are some trials or studies that looked at this, and all of them which are feasibility trials, phase 2. For Trek and Star Trek, they will be looking at recruitment rates. That's their primary outcome. And although they may have powered to look at the response to treatment, is not actually looked at is not powered to look at the oncological outcomes, actually. CARTS was a single-arm study that looked at T1 to T3 N0M0, looking at chemoradiotherapy with a good response then TEMS. But a third of these patients only went on to TME. But interestingly, about 50% in those that had organ preservation had major LARS. That's the non-operative group. Star Trek is looking at TME versus operation after short course radiotherapy or operation after chemoradiotherapy. And we will wait for the results of that with interest. And organ preservation is the goal using this approach after neoadjuvant therapy. Now, let's keep the CART study in mind when we explore some of the data out there in terms of functional outcomes. I've shown Soren Lauerberg and Katrina Emerson from Denmark in this slide here, who have been instrumental in our understanding of functional outcomes after rectal cancer treatment. We know that after surgery, there are some impairments in function, but after neoadjuvant therapy, and indeed after adjuvant therapy, these are much worse. So radiotherapy does impair function to a far greater degree than going straight to surgery. That has an impact on quality of life. We know that neoadjuvant radiotherapy produces a 2 to 2.5-fold increase in major LARS. We know that TME in itself produces such an outcome. Being younger and being female are also higher risk factors in terms of significant or major LARS. You look at the Dutch TME trial at 14 years, there was an odds ratio of about 3 after neoadjuvant radiotherapy for major LARs. So we need to analyse the impact of radiotherapy on pelvic functional outcomes. We know that in men, that erectile dysfunction is impacted by erectile surgery. It does not seem to be significantly different between restorative TME or PME alone, but if you it's certainly worse than colon surgery. But if you add radiotherapy, there's 2 to 2.5 odds ratio of male sexual dysfunction, and that's also increased with an abdominal peritoneal. Female sexual function is also significantly impaired after a permanent stoma and radiotherapy. Now let's talk about pelvic sidewall nodes. Now we go back to Lord Moynihan, who posited that surgery for cancer is surgery of the lymphatic system. It has been our view that lymph nodes as part of the lymphatic system are, when they're pathologically involved, but are left behind after surgery, they will represent a source of disease recurrence, both local, regionally, and systemically. And as such, the treatment should be focused on eradicating all of this nodal disease on the assumption that it is involved in that. And we've generally assumed that tumours follow a mechanistic stepwise progression of metastatic disease, and that has been very much our dogma. But actually, if you look at the science and look at some of the autopsy studies, it probably only applies to around a third of patients. And the autopsy studies confirm this disparity, and it's likely that there are alternative pathways. There may well be some tumours will go to the lymph nodes and are retained there like a sponge, and some will be released. But the majority of metastatic disease appear to have a different clonality in terms of phylogenetics, those arriving in the lung or liver appear to have a slightly different signal to those that go to the lymph nodes. But irrespective of what the mechanisms are, node-positive disease still reflects generally poorer outcome. Now, given our limited understanding at present, it's accepted that we should perform en bloc mesenteric lymphadenectomy for both colon and rectal cancer to remove all the primary tumour, its regional lymph nodes, and blood supply. Whether we need to do this with earlier stage disease is more contentious, but whether we need to do more for locally advanced disease is also contentious. But what is clear is in the absence of any detailed histopathological assessment of lymph nodes involvement, deciding and predicting if a lymph node is involved is extremely difficult. And as a result, we end up using various surrogates to guesstimate the likelihood of involvement, and most of that is based currently on MRI and CT. But that sadly remains dismal in relation to the nodal disease and histopathology assessment. Now, it seems to be entirely fine to remove all the lymph nodes if you're doing a TME and a CME, but the problem lies in what we do if there's nodal disease out with those areas, for example, in the pelvic sidewall, as you see in this slide. And until we can better predict whether a node is truly involved or not, we're still going to default to removing all of these areas. And pelvic sidewall disease is one of those burgeoning areas of interest. Now, one of the things that still is incongruous to me is that radiotherapy has been said is that radiotherapy does not compensate for incomplete surgical resection. And that's pretty much every radiation oncologist I've ever worked with has said that. Yet radiotherapy, we know, produces complete responses in some patients. We've seen that earlier in this talk. From the old rectal cancer trials, we know that histopathologically involved mesorectal lymph nodes are associated with a 2 to 3-fold increase in local recurrences. We know that in stage 3 cancer, radiotherapy reduces local recurrence rates, but with an incomplete TME or rectal resection compared with complete TME, the local recurrence rates are significantly different, between 20% and 6%. And that means that a principle that radiotherapy doesn't compensate, does that actually apply to the pelvic sidewall? And is radiotherapy enough to sterilize these potential lymph nodes as proposed? But it might be that they were never involved in the first place. Now, this approach to this dilemma has been different across the globe. There's been significant dichotomy between the East and West. In the past, we both adopted an aggressive approach, say Halsterian approach. And in the West, we figured out in the 50s and 60s that it wasn't always suitable to do this, given the morbidity associated with the procedure. However, in the East and in Japan, they continued to do this with increasing skill. And in the West, we found utility in neoadjuvant therapies. And in the East, they became more detailed as patient selection. And how we view nodal disease is also different in the East and the West, with nodes above the internal iliacs being regarded as metastatic disease, whereas in Japan, they're regarded as regional disease and therefore a more aggressive surgical approach is applied. So the question is, how often do we see involved lymph nodes in the pelvic sidewall? Well, it depends on when you look at it and how you look at it and how you choose to classify it. Pre-op, it's highly variable, as you'll see in this slide. Post-op, it might be around 1 in 5 to 1 in 2, depending on where you look. Now, Brendan and Hideaki Yano looked at this in an article some years ago, over a decade ago, tried to estimate the number of lateral pelvic sidewall lymph nodes that might be there. You can see that it seems relatively small numbers overall, and mostly in low rectal cancer. Our own radiologists have tried to look at this in their own practice, around 400 MRIs. They've looked at that to see how many might have pelvic sidewall lymph nodes. It's small. That whole cohort had around less than 5%, not just based on size, but looking at suspicious features. And of interest, when you compared the pathology with the MRI, there was significant disparity between the number of MRI-involved nodes and the number of histopathological involved nodes. And indeed, the kappa was around 1.2, indicating how dismal it is in predicting the nodal disease status. Now, when it comes to location within the pelvic sidewall, there are different areas that we talk about. There's external iliac, as you can see in red, there's the obturator seen in the green, and then there's internal iliac. The way I would remember this is the internal iliac is medial to the internal iliac vessels, and the obturator lies between the external iliac and the internal iliac territories. Now, when it comes to the evidence for all of this, there's a dearth of randomized clinical trial data, but there's only one trial that I'm aware of that comes from Japan, the JCOG 0212. And adding prophylactic lateral lymph node dissection to TME versus TMA alone produced a significant difference in local recurrence, and that was mostly within the lateral pelvis, as you will see here. That, however, didn't really compare significantly in terms of disease-free or overall survival, although it did have an impact locally. And if you look at the function between these groups, there was no significant differences, although there was significant rates of male sexual dysfunction in both arms. And there's an evolving interest in whether this should be done laparoscopically or robotically, and it does appear there's probably not a huge amount of difference between robotic and laparoscopic at present. However, when you compare it compared to open surgery, there does appear to be benefit to a minimally invasive approach. We have some non-randomized data registry data from the Lateral Node Study Consortium, looking at T3-4 low rectal cancers, and this was a multi-center cohort looking at the size of lymph nodes and MRI in response to treatment, and this was associated with local recurrence. And most of these local recurrences were located within the pelvic sidewall, suggesting entirely local regional disease. And it seemed that excising these persistent nodes improved local control, and that had to be complete removal of the pelvic lymph nodes rather than sampling, as that also appeared to increase the local recurrence rates. Again, this did not appear to impact upon disease-free or overall survival, and appeared to be an entirely local phenomenon. And still much work needs to be done in this area to establish the treatment response and pelvic sidewall lymph node distribution. And indeed, the LANAREC trial has been set up by our Dutch colleagues in order to do this. So I will conclude in the interest of time. I think lymph node metastasis influence survival and are related to poor prognosis. The role and relevance of nodes in metastatic diseases under review. Removing truly involved lymph nodes probably improves local control, but unfortunately identifying them remains very difficult. And indeed, the MRI, despite good for many other things, is dismal for this. It's potentially morbid, and that morbidity may negate benefit. And it's important that we do not end up over-treating patients based on the inadequacies of the preoperative imaging. Thank you very much.
Thank you very much, Ian, for this great presentation. Walter has been really active on the background and is driving Maite crazy with inventing polling questions. So Maite, I think we have polling question 4 now for the audience, just to see what everybody's doing at their home countries. So this is the questions: are you performing exenterations in your own hospital? And what's the number? So the answer is no, less than 5 a year, between 5 and 10 a year, and more than 10 per year. So please take the time to answer this. And I'm really interested in Ian's opinion after these 2 polling questions, what he thinks should be the numbers. So the majority is not performing exenterations, which is interesting. And there only a fraction is doing a few a year. So thank you very much. And the next polling question, so polling number 9, Maite, and this is about centralization. Should advanced colorectal cancer be centralized in your country? The answer is yes, don't know, is already done or on the way, or no. Please take the time to answer this. So the majority says yes, don't know, and only a fraction it's already centralized. So there are a lot of countries where there are actually not really rules about this. So Ian, I have a question for you. How is it organized in your country? And do you think this type of surgery should be centralized?
I think that's a very good question, Colin, and it really depends on the healthcare system that you're within. It also depends what you mean by advanced disease. I think we know that for hepatic metastatic disease, that's all very highly specialized within the HPB world, so that's not an issue. Most lung resections, if they are done for metastatic colorectal cancer, are done by thoracic surgeons. But the more contentious areas are locally advanced rectal cancer. Should that become more centralized? And I think that is a direction of travel that is happening in the UK. And I think Brendan might add to this. There's an initiative that he was involved in called PIPAC that tried to better inform MDTs and clinicians involved in the multi-specialty care of colorectal cancer, advanced colorectal cancer, as to what pathways there might be. And we certainly see more and more referrals coming through what we might describe as specialist centres. For colorectal peritoneal metastasis, which Brendan will chat through, I'm sure imminently, then that is most certainly done at the hyper-specialist level and is commissioned officially through, centres are recognised by the NHS to do so. In terms of pelvic exenteration surgery, there are centres that are regarded as suitable to do that, but it doesn't necessarily follow the same structure as the peritoneal malignancy, be that CPM or pseudomyxoma type centres. So it's a little bit more nuanced, but I think the direction of travel probably in terms of quality of care is that we should be more centralised in how we manage these cases. But how to define which cases should be managed within specific centres, that's still another piece of work that needs to be done. I hope that makes sense.
Yeah, it really makes sense because it's pretty comparable with the Netherlands, where we centralize these types of surgery as well. But we have a big discussion how many procedures you should do per year to become a center of reference. And specifically with lateral lymph nodes, that's really difficult because there are not that many. And there are a lot of surgeons which like the type of surgery and want to participate. So it's like
I think that's a great danger, is that it depends on the system that you're in. And for a more socialized healthcare system, I think you can be more polarized in the clinical practices. When there is a potential fiscal gain to surgery, I think that becomes a little bit more grey in terms of which centres will choose to do these sort of things. And I think that is a more concerning sort of aspect to this for me.
Yeah, I agree. So thank you very much, Ian. Walter, do you have a question or something to add?
Actually, as we have those cracks here, and you saw the numbers which were listed by the participants, regarding the technique, Ian, you did not talk about too much of the technique, and now the robot is coming up. Do you think that robot is doing the exam duration better, and if we see the numbers, how many should you have to do that? What do you think about it?
I think the robot, well, it's a new technology. It will be applied like any new technology. It will have a bit of a pendulum to it that people will try and do it too much, then they'll realize what it can be used for. I think it can be used for central disease. I think it can be used for certain central recurrences, provided there's not been too much pelvic disruption. I think the robot, whilst it is huge benefits in terms of the optics, the haptics are obviously always going to be a potential concern. And part of the surgery that we do for disease within the pelvis still requires some degree of sensation in the fingers to determine what tissue planes can be followed safely. And there's still a degree of digital dissection goes on in some of these more complicated operations. I think it's an evolution. I think robotics will offer more. Whether minimally invasive surgery truly offers global benefit to the population of exenteration patients, I'm not sure. I think posterior exents and total exents with central disease probably is the direction that they will go in. For disease that's involving bone and going deep into the blood supply of the pelvis, the pelvic sidewalls, I think it's still very, very difficult to do any of that minimally invasive. I think the robotic technology will continue to improve, but at the moment, the energy devices that it has, these sort of sealers, vessel sealers, are still very cumbersome. And I think if you were to get a significant bleed from a major vessel within the pelvis, particularly the pelvic sidewall, you would really struggle to control that, I think. That said, I think suturing and all the other bits and pieces that come with the wristed instruments, I think are far superior than anything else that we've got. In terms of our lessons from minimally invasive exenterative surgery, I think I said before, they all do really well within the first week because they don't have a big cut, the pain is less, but they do have a big hole and a big cavity in the pelvis, which ultimately gets filled up with fluid that either gets infected or it gets filled up with bowel that gets stuck and they get partial obstructions or they get prolonged ileus. So how to fill that pelvis better is still something we have to think about, I think.
Yeah. We had that in the lecture, so this is also for all the participants which are here now. You can look up the former webinar series we are having, and Maite will send the link to everybody that you see. So this was one of the topics, how to fill the empty space in the pelvis, and this is a major topic. So thanks, Ian. We are going forward, and it's a pleasure to have Fernando Rotella here. As it's mainly the disease which also covers the liver, and this is why we put it in. And I would ask a question before to the audience again, and Maite, can you bring the polling about the interdisciplinary tumor board? As we realized in our last webinar series that not everybody has a mandatory tumor board interdisciplinary for colorectal patients. And this is the question for you. Do you have that mandatory? Do you have it before or after surgery, or maybe before and after surgery? Or is it only on demand that you choose, or the gastroenterologists are able to choose? So please make that polling, and please also use the question and answer section. You can really do it in between, because we want to have a lot of questions. Use the time for the cracks here. So, okay, we see that 2/3 of all have before and surgery mandatory, and some only before, only on demand. But nobody has no interdisciplinary tumor board. That's good to know, because sometimes the liver surgeons have to come first. So Fernando, it's a pleasure. Please give your lecture.
Well, thank you very much. Well, it's a pleasure for me to be here. Thanks to Medtronic and in particular to Maite for the invitation, and also to you for hosting me. So before my presentation, I would like also to perform to a couple of questions to the audience. Maite, the first one is, do you have experience in laparoscopic simultaneous liver resection and colon resection? Yes or no? Minimal invasive simultaneous resection of metastases and colon. Well, an important number. Not the whole audience, that 40% is okay. And the second question is, when performing simultaneous liver and colorectal surgery, who does the liver resection? Colorectal surgeon, for example, you or other, or an HPV surgeon? Well, 70% versus 30%. Okay, so great. It's interesting. So I'm going to share my screen. All right. So to be the representative of HPV liver surgeons among so many colorectal surgeons is our responsibility. And well, I'll try to do my best. So the context, well, as you know, liver metastasis or liver is the most common site of distant metastasis. And at the time of diagnosis, about 1/4 of the patients will have liver metastasis, and a similar proportion will develop distant metastasis during the follow-up. And also, you know how there is no possibility of cure without surgery, just with observation or with chemo. There is no long-term survival in patients with colorectal liver metastasis. So in this context, which is the rationale, which is the current evidence to perform minimal invasive liver surgery? Well, of course, this is the most obvious effect, but we must measure the results according to more objective aspects like costs, surgical and oncological outcomes. For many years, we didn't have a high level of evidence regarding all these aspects. Most of the series were retrospective, and most of the series included the learning curve of the centers. Unfortunately, recently we have two randomized controlled trials that compare laparoscopic versus open resection for colorectal liver metastasis. The first one is this one. This is the first randomized controlled trial from Norway, the Oslo Comet trial. This is a well-designed study. They began the study after they had concluded their learning curve. So it's a very experienced team. And the primary outcome was complications, and the secondary outcomes, several other interesting aspects to compare. And the results is that laparoscopy offers less number of complications and less severity, statistically significant. Also, with significant statistical significance, less hospital stay, less use of opioids, improved quality of life, and although the procedure itself is more costly, at the end, the result is favorable to LAP. This group also offered a long-term oncological study with similar results, laparoscopic versus open. This is the second randomized control trial. This is the Spanish trial, open versus minimal invasive, because this included also hand assisted. This is a well-matched study, and the results also offers significantly less number of complications, shorter hospital stays, but with similar oncological outcomes. So far, we have a strong evidence on the benefits of the minimal invasive surgery for the treatment of colorectal liver metastasis in cost, surgical, and with at least similar oncologic outcomes. I'd like to study on depth these two columns, because we tend to contemplate these like different, that they are different things. And in fact, we should break this concept and study the possible interactions between the surgical outcomes and the oncological outcomes. We don't have much time to study all of them in depth. I'm going to only to tell the results of the impact of morbidity on the oncological outcomes. For example, well, there are many studies. These are recent meta-analysis that confirms that the complications after resection of colorectal liver metastasis has an impact that is significant on the overall survival and the disease-free survival. And this is a very interesting paper too, that predicts that confirms that the cancer-specific survival after resection colorectal liver metastasis is affected by the CCI in a way that is even superior to the RAS mutational, or the effect of the RAS mutational status. And this effect of morbidity on the oncological results is always being reported in transfusion rates, the possibility of early chemo, the possibility of resection, and also the inflammatory response that is significantly lower in minimal invasive liver surgery and affects significantly on the oncological outcomes. There were two meta-analyses that studied this effect of the laparoscopic approach in the long-term outcome. This is from 2014, this is from 2017, and they observed a benefit of the laparoscopic group after 3 years of follow-up. These studies were not taken or considered too seriously because of the low number of studies, or because in this case, probably the selection criteria of the studies that were included were not too strict. But last year, it was published this very, very interesting paper that includes only data from very solid studies, the randomized controlled trials or propensity score matched studies. And it confirms with a solid evidence that the laparoscopy has a beneficial effect on the long-term outcome after resection of colorectal liver mets. That is evident after 3 years of follow-up. And the reasons for this benefit are those that we have commented before. Less morbidity, early access to chemo, lower inflammatory response, etc. So now we have solid evidence that confirms that laparoscopic approach is not only a standard of practice, or should be considered a standard of practice, but I think it paves the way towards accepting the minimal invasive approach as probably in a near future standard of care. Some words about the options in synchronous metastasis. This is why I did the question. As I am presented before, the possibilities of clinical presentation are very, very complex. We have many options. There are many clinical guides, and in any case, the decision should be taken in a case-by-case basis in a multidisciplinary team. But considering that most of you are colorectal surgeons, there is a scenario that is of high importance to you. Is what to do in synchronous disease, simultaneous resection, colon first and then hepatectomy, or liver first. Well, there's many studies that offer different views of this reality, of these possibilities, but this interesting meta-analysis studied the three possibilities: simultaneous resection, delayed, and liver first. And they conclude that after a very strict study that none of this possibility has any superiority, has superiority over any other of them in terms of survival or perioperative complications. So the evidence at present supports the application of any of the three surgical strategies, provided that they are applied to carefully selected patients. So which carefully selected patients can we treat with simultaneous minimal invasive liver and colon resection? Well, for sure, not those patients requiring major hepatectomy. We know that the simultaneous colorectal and major hepatectomy has a high proportion of mortality or morbidity. So no major hepatectomy. This paper, this Spanish paper, offers a very interesting view of when performing minimal invasive combined resection, or better said, when not, in fragile patient, in major hepatectomy, or in symptomatic or low response tumors. How to perform this simultaneous resection? The general recommendation is to perform the liver first, because if we have a bleeding or if we want to perform Pringle maneuver, it is better to do the Pringle without having done the colorectal surgery, because the congestion, the splanchnic congestion may cause bleeding from the surgical field or may put at risk recently done anastomosis. So liver first and then colon when performing simultaneous. And with which kind of resections? Well, the recommendation is to perform mostly minor superficial or wedge resections in the so-called laparoscopic segments that are the anterior or inferior segments. For many surgeons, the posterior superior segments are considered a major hepatectomy or more difficult technical hepatectomies. So how to do these wedge or minor resections? Well, in these first 2 centimeters of the liver, there are there are no major vessels, so we may use almost any energy device. We don't need no specialized instrument. So with any energy device like Ferglicasur or any vessel sealer, we can progress very safely, occasionally doing cross clamp, as we can see here, cross clamp, and then seal. This doesn't run, I'm sorry. Well, but you see how we can progress and eventually complete the transaction with just energy device. For the second procedure that we can do simultaneously, and for me, this should be the largest procedure that we could do simultaneously, is the left lateral sectionectomy. A left lateral sectionectomy, for those that are not familiar with it, is one of the simplest procedure to perform laparoscopically, because in most of the transection plane, there are no vessels. The pedicles and the vein are very far below, and they are located like the 3 in a row. So we can progress with the energy device, and at the end, insert the endostapler. Let's see the video. See how we have divided the falciform ligament. We advance lateral to the falciform ligament, and we progress with the energy device, advance progressively in layers, and try to avoid digging into the parenchyma, just layers and layers, and eventually we have completed the transection. The liver has opened as a book, and we can insert an endostapler, divide the liver, the pedicles, the endostapler, and then a second endostapler to divide the vein in the upper part. This is it. And this is the final aspect. As commented in all the transection, there is no vessel, so we can progress with energy device, and at the end, the staple lines that, as you can see, they are the 3 in a row. So, which is the state of the art, which is the current procedures that we are doing under laparoscopic approach. And I'm going to talk about the principles that we must follow in minimally invasive liver surgery, but in particular for colorectal liver mets, and then on technique and the technological advances. For those that are not familiar with liver surgery, there's this concept of parenchymal sparing technique. When we have we have 2 identical situations, and we can perform this parenchymal sparing doing local resections with free margins and local resection of the lesions, or we can also be radical but performing major hepatectomies. The thing is that when the recurrence takes place and we have done a parenchymal sparing, we still have options to do a rare resection. But if we have been done a parenchymal sparing, there are not further possibilities. And this has an impact on the outcome. We can see how the recurrence-free survival is similar for both procedures, but the time to last unresectable recurrence is much shorter when we don't do parenchymal sparing surgery, and also the overall survival is lower when we do major hepatectomies instead of parenchymal sparing resection. And the second concept that is of utmost importance is the concept of remnant liver ischemia. When we perform liver resection for colorectal liver mets, we can have a marginal ischemia, segmental ischemia, and partial ischemia or segmental ischemia. And these two grades have a very important effect on cancer-specific survival when compared with no ischemia. So when performing minimally invasive liver surgery for colorectal liver mets, the surgeon should resect all detected disease, preserving as much healthy parenchyma as possible, and being minimally invasive because of the benefits we have commented before. Technical aspect of minimally invasive liver surgery. The first one is how to take advantage of the pneumoperitoneum. When compared to open surgery, the minimally invasive or laparoscopic surgery works for us like a pressure chamber, so that there is like a balance between the CVP and the pneumoperitoneum pressure, and we can take advantage of this situation. And if you have a very low CVP, we can do a totally bloodless transection. While if we have a high CVP, we may have bleeding, oozing from the liver, and we will be very, very difficult. So we must take this into account. This is an example of the two situations. Low CVP, this is the same, exactly the same procedure. Here we are detaching the liver from the portal bifurcation. With low CVP, it's easy to do. We can very easily recognize the structures, while with high CVP, there is a continuous oozing that prevents us from progressing, and eventually we give up. So it is really teamwork. The anesthesiologist plays a very important role, and I always say they are even more important than we are when performing laparoscopic liver surgery. And thanks to them, we can perform really, really bloodless transections, and they allow us to identify the intrahepatic structures. And a second technical aspect that is very, very important is the concept of the caudal approach. It has been highlighted as the main conceptual change in laparoscopic liver resection when compared with the anterior approach that we had in open surgery. When performing this laparoscopic, we have this caudal view that really changed the way we understand liver anatomy and the way we understand liver surgery, because perspective really changed the way we see the objects. And particularly when talking about liver, this caudal view offers a very nice exposure of the hilar plate, and then favors the performance of Gleasonian approach. As you know, the portal triad, or the Gleasonian triad, is like a tree. So there are several branches, first order, second order, and third order branches. So we can selectively clamp or divide one of these branches and its territory. And this is preferentially done under the laparoscopic approach, thanks to this caudal view. Here we have an example. The magnification we have with laparoscopy and also this caudal view offers here an excellent view of the hilum. Here we are individualized or dissecting the right anterior portal pedicle that is extrahepatically individualized. It is clamped and will come later to the ICG, but allows to selectively clamp one of these Gleasonian pedicles and do a very precise anatomical resection. And the caudal view also offers us the possibility of perform venous approach, because also offers a very nice exposure or access to the root of the veins. And thanks to this privileged view that we have under laparoscopic approach, and also the possibility of do a bloodless transection, we can perform vein-guided resection. Look, this patient with liver metastasis here in the segment 7, the upper part of the liver. This is the right hepatic vein, and we will use the right hepatic vein as a reference to perform a safe R0 resection. You can see here how we have mobilized the liver. We are following the route of the right hepatic vein, and from the root to the periphery, we are dissecting and mobilizing the specimen until we conclude the transection. I don't know how this doesn't work. And this one, this is the specimen removed. We have performed an R0 monitoring the margins throughout the transection in a priori difficult location, thanks to the caudal view. And also this other example, liver metastasis, colorectal liver mets, 1 centimeter from the right hepatic vein, 8 millimeters from the mid hepatic vein located here. And we will use the major hepatic veins as a reference to perform an R0 resection. Here is the metastasis. This was the right hepatic vein. We come here to dissect the mid hepatic vein and advance from the root of the mid hepatic vein to the periphery, following the vein that is our safety margin. And well, following the mid hepatic vein, we will find the portal pedicle. And then we follow the right hepatic vein that was our other margin. And we have done a safe resection thanks to this vein-guided optimal view we have in laparoscopy. And finally, technology has really been a game changer when doing laparoscopic liver surgery. I like to talk about 2 elements. The first one are the 3D reconstruction softwares. There are many softwares in the market, and they help us to do a 3D representation or that help us to identify the anatomical relation of the tumors with the vascular structures, and eventually to do a proper planification of the resection. For example, in this case, we can see the portal territories, and we can see this lesion and how, if we divide here, we may leave some ischemic territory here. But we might do a planification of the resection, warranting that we are leaving healthy parenchyma after the proper resection. And the second element is the ICG. You had a whole webinar on ICG on colorectal surgery, and in liver surgery it has also been a game changer, not only in gallbladder but also in liver surgery. We can clamp the pedicle, inject ICG, and perform a very precise anatomical resection. Look, these are colorectal liver mets that is in between 2 Gleasonian pedicles that converge here. So we should clamp here and resect all the territory if we want not to leave a ischemic remnant. So we will divide this Gleasonian pedicle for segment 8 and preserve this one for segment 5. This is at the lateral side of the gallbladder, as you can see here. So we are going to come here to find this pedicle. Well, this is the endo-ultrasound that is mandatory in laparoscopic liver surgery. Here is the gallbladder. We are going to identify, thanks to this caudal view, the Gleasonian pedicle for segment 8. We put a clamp, inject ICG, and it will define exactly the territory that we must resect if we want to do a precise resection without leaving ischemic parenchyma. ICG does not only define the superficial margins, but also along the transection. So it's amazing how we progress, and also thanks to the elements I have discussed before, pneumoperitoneum, the possibility of do a bloodless transection, a vein-guided transection, and well, we progress very safely, very fast, and eventually we have found the clamp that we have inserted from below. We remove the clamp, divide the pedicle after ligating and double clipping, And here we confirm that all the parenchyma, the remaining parenchyma, is very well vascularized. Along the years, we have been pushing forward, and at present, more than 90% of the cases in colorectal liver metastasis are performed laparoscopically, and we are continuously breaking barriers. Recently, we have approached even vascular resections and reconstruction. This case, huge colorectal liver mets that invades the portal vein, and we, under laparoscopic approach, we have divided the liver here, and well, we put a clamp on the main. I will not show all the video, but because there is no time, I don't know why this doesn't work. It will divide the portal vein, suture this stump here, and then reconstruct the portal vein. And well, this is the reconstruction. This patient was discharged on the third postoperative day, thus beneficially, that benefiting from the minimal invasive liver surgery. So, and preparing this webinar, Walter suggested some technical tips that could be of help for you that are maybe not too familiar with liver surgery, but eventually need to do liver resections. So I'm going to share very rapidly three or four most important lessons, in my opinion. The most important one is to perform a Pringer or prepare a Pringer maneuver. This was a case, a very simple resection in a peripheral lesion, and well, in this patient, well, we had a bleeding just with the vessel sealer, and well, we couldn't control, and we need to convert this case because we hadn't prepared a Pringer, because initially it seemed to be very easy to do. So my recommendation is, whether you are going to use it or not, prepare a Pringle. Here is the reference on how to prepare. It's very easy to do. We put a tape around the hepatic pedicle. It is sterilized at the level of the future suprapubic incision, and we advance from the suprapubic incision. The tape is left below, so it doesn't interfere with the procedure, and it is very easy to clamp from the outside and perform these procedures. The second useful tools are the use of barber suture. I'm sure you're familiar with it. And when we have a bleeding, they are very, very convenient in liver surgery. Here we have a tearing. You can see how dramatic can be the bleeding in liver surgery. We had prepared a Pringle, so we clamp. It immediately stops. You can see how effective is the Pringle. And then with a barber suture, we close the. So you don't need to tie. You just pull with the minimal tension required, and you control the bleeding very effectively. Another case, bleeding here, and again we put a stitch, and with no need to tie. From the self-locking sutures, it controls the bleeding, and is I have always it prepared at the bedside. Maybe in more advanced procedure, vascular clamps that are very, very convenient. If you don't know when you're going to have a major injury from a major vessel, and in this case, we had a bleeding from the cava. Well, if you are used to do this in open surgery, in laparoscopic surgery, we can do the same. For all, maybe these are very advanced procedures, but it is very, very useful. And for me, it's an indispensable tool. And finally, if you are going to do left lateral resections, one of the most dangerous moments is the mobilization of the left hemiliver. This is a very typical complication, trying to do the mobilization from the periphery to the root. This is a classical injury, and there are very dramatic consequences because of injury of the left hepatic vein here. So the advice is always to follow the phrenic veins. They will tell you where is the left hepatic vein, also the right, but for left lateral, the vein, and do this dissection from the root to the periphery. And well, once we control bleeding and know how to handle it, really it opens the door to the most advanced procedures. To conclude, three rapid take-home message. We have seen how evidence reassures minimally invasive liver surgery as a standard procedure. And in my opinion, in a near future, it will be a standard of care. We have seen how simultaneous liver and colon is a good option in selected patients. And finally, how technical and technological advances allows us to perform very precise, minimally invasive anatomical liver surgery that results in better procedures for the benefit of our patients. Thank you very much for your kind attention.
So Fernando, thanks a lot. You saw that we were running out of time, but it was extremely excited. So I think we did not stop it, because for later on, if you look it on the webinar, it will be brilliant. So thanks a lot for those nice pictures, for those that people see what is possible and what could be done, and maybe transfer to hospitals where this is done, because we really think this is an advantage. I would now propose that we directly go ahead, Colin, because we will have questions for you, of course, in the end, and people should use that. I have a list of questions which would be interesting, but I think we should have Brandon now to talk about the HIPEC and the more advanced peritoneal carcinosis. And I guess we have some questions for Brandon. Maite, can you bring in? So the question is, in your hospital, for the audience, are you doing cytoreductive surgery? Are you doing it at all? Are you doing less, 5 to 10 or more than 10 per year? So that's the first question, because this will be interesting also to see how people are dealing with peritoneal carcinosis before Brandon is starting. Okay, we see mainly it's not done in their hospitals. So then we just add the second one, which means, are you aware of the inclusion criteria if your hospital does not offer? Are you aware, yes or no? And the third option is, are you working with a hospital offering the tumor board and the HIPEC? So if you're not sure what is the inclusion criteria, do you present everybody to a tumor board and the partner hospital? So I think this would be important. Okay, so I hope that Brandon will answer why you should go for a tumor board with CSZ HIPEC option in other hospitals, or make it yourself. Please, Brandon, go ahead.
Thank you to Walter, Colin, and Medtronic for organizing this symposium. I've been asked to speak a little bit about peritoneal carcinomatosis, and indeed about the treatment of peritoneal carcinomatosis. In the 1990s, which seemed a long time ago, but when I started in surgery, carcinomatosis was a very common problem, and there was no concept that there was any role for surgical treatment. And there was this rare condition called pseudomyxoma peritonea, which was thought to be a tumor that started in the ovaries and was exclusive to women. That's changed, of course, quite a lot since then. And in those days, the role of imaging was beginning to emerge, and we had MRI, CT, and the beginnings of PET-CT. As somebody alluded to already, I work in Basingstoke, and most of you will be familiar with Bill Heald, who still works with me, aged 85 or 6. I'm not quite sure what age he is, but he's still doing some work. He's traveling around as best he can. He's been in Portugal at the moment. And you will see on the top right-hand side this iconic drawing from the British Journal of Surgery, 1982, about the concept of total mesorectal excision. At the bottom, and I think is partly covered by the panels, you will see an MRI scan. And we have spent a lot of our time and energy both involved in the surgery, but also in the staging of rectal cancer with Gina Brown and others, and trying to optimize outcomes by selecting patients who can go straight to surgery and selecting patients who need neoadjuvant therapy, as Ian has already alluded to. Now, in the 1990s, when I started as a consultant surgeon, these three pictures on the top left, you can see pseudomyxoma peritoneal jelly belly. The bottom is a big cystic mass, which in fact was cystic mesothelioma. And the panel on the bottom right is two small nodules of cancer in a patient who had a previous colorectal cancer. At that point in time, again, there was nobody really who knew what to do with any of these conditions, as far as I know. And this man, Paul Sugarbaker, actually has developed a world society and a world interest in treating these conditions. This all began when Paul was a research fellow. Some of you will have met Paul. It seems a long time since he was a research fellow, the 1970s and 80s. And in a US trial, patients with colorectal cancer were being randomized to systemic intravenous 5-FU versus intraperitoneal 5-FU. And in a small number of patients, they went on to have second look laparotomies at 6 months. And what Paul Sugarbaker and his team noticed was that there was a marked reduction in peritoneal carcinomatosis if you had intraperitoneal 5-FU. And so he used this knowledge to apply the treatments, a local regional treatment for peritoneal malignancy, particularly low-grade tumors such as pseudomyxoma peritoneal. Pseudomyxoma peritoneal is relatively rare, but actually has provided us with a lot of knowledge around the diagnosis, management, and treatment of peritoneal cancers. We did a first case in Basingstoke with surgery and intraperitoneal chemotherapy in 1994. It took us 14 hours to remove a pseudomyxoma completely, and we gave intraperitoneal 5-FU. We have gone on to develop this. You'll see on this timeline, it took 8 years to do the first 100 cases. And now we have, by 2017, we've done 2,000, and we've now done over 3,000 cases. So it's an increasing entity for us, predominantly initially for pseudomyxoma peritoneal appendix tumors, but now approximately half of our patients are patients with what I call colorectal peritoneal metastases. Now, there's probably a language that you need to pick up on around the whole aspect of peritoneal disease. Carcinomatosis is a bad term because there's really nothing curative we can do in surgery for carcinomatosis, which means generalized spread of cancer all over the peritoneal cavity. And so we've moved the terminology a little bit, and we talk now about peritoneal malignancy, which also includes low-grade tumors such as pseudomyxoma peritoneal. There is a whole area of surgery which we have labeled cytoreductive surgery. And of course, we have used the Dutch term hyperthermic intraperitoneal chemotherapy. There is a very important phenomenon which we've learned from pseudomyxoma peritoneal called redistribution, and I'll come back to that in a moment. And we have tried to say that rather than a focus on carcinomatosis in colorectal cancer, we should focus on what we call colorectal peritoneal metastasis. Like liver metastasis, as Fernando told you, you cannot resect the whole liver if there's metastatic disease. You cannot resect the whole peritoneum. It's impossible. And we have two systems which we use, the peritoneal cancer index, the PCI, and then we have the completeness of cytoreduction when we have operated on these patients. As we all know, unfortunately, despite our best efforts with screening and so on, it's very common for patients to present with advanced peritoneal disease. And we encounter patients with gastric cancer, pancreatic cancer, and colorectal cancer with diffuse carcinomatosis, and there's very little we can do for those patients. Ovarian cancer, of course, is also a very common problem. And even as general emergency surgeons, we come across all these patients in our emergency take. Just to give you an example of a patient, this is a young lady from Dublin called Lisa, who had a laparoscopic anterior resection in 2010 for rectal cancer. Rather strange because she had no family history. And at the time of the operation, the Dublin surgeons found limited carcinomatosis, which they didn't resect because it was near her ovaries and her uterus. And like a lot of young patients that we all see now, she had a very aggressive cancer, a signet ring cell, with 21 or 24 nodes positive. And so she had laparoscopic anterior resection, systemic chemotherapy for 6 months, a normal CT scan in November 2011, and then progressive abdominal distension about 3 months later. And this is her CT scan, which was taken in middle of March 2012. And you can see 2 large masses in the lower abdomen. And these are in fact Krukenberg ovarian tumors. And rather dramatically, despite this huge volume of disease in her ovaries, the small bowel was more or less completely normal. And we were able to do a complete cytoreductive surgery on this young lady. She unfortunately died a couple of years later from progressive disease, especially nodal disease obstructing both her kidneys. And the question is, what is happening in this young lady's abdominal cavity? Well, it's related to peritoneal physiology and pathophysiology. We all have fluid within our peritoneal cavity. It's absorbed in 2 particular areas. One is in the greater omentum and the lesser omentum, and the second is on the undersurface of the diaphragm, particularly on the right side. And the redistribution phenomenon, which we've learned from pseudomyxoma, but applies to all motile cancer cells within the abdomen, is that you get a concentration of tumor at the sites of normal peritoneal absorption, and you get relative sparing of the mobile organs, especially the small bowel, and you get a contribution from gravity. And this is a cartoon which is based on pseudomyxoma peritoneal, but it illustrates the sites of disease within the peritoneal cavity, the greater omentum, right subhepatic space in the pelvis and under the right diaphragm. And so you can see this is a patient with pseudomyxoma, disease on the right diaphragm, right surface of the liver. You can see this is a very large omental cake of tumor, and the small bowel is practically normal, which is quite fascinating. And you've already seen the effects of gravity in this young girl with the rectal cancer. And the whole concept of cytoreductive surgery and hypothermic intraperitoneal chemotherapy, CRS and HIPEC, is a combination therapy to treat and to prevent, if possible, peritoneal malignancy. The concept of HIPEC is that you heat chemotherapy agents to 41 to 43 degrees for 30 to 90 minutes, and it's commenced after cytoreductive surgery. When you've removed the disease, you then commence with a hypothermic intraperitoneal chemotherapy. Heat actually promotes the effect of a number of agents that we use in the peritoneal cavity, mitomycin and so on. For pseudomyxoma, which of course is a low-grade, non-metastatic in general tumor, there are a number of very extensive procedures which we do, and it can include an anterior resection and a partial or indeed even a total gastrectomy. And as I left the hospital today, we'd just done a partial gastrectomy and a total colectomy on a patient with pseudomyxoma peritoneal. Of course, these are very extensive procedures which would not work for somebody with colorectal cancer. For pseudomyxoma, there's a lot of evidence, but it's not randomized evidence, that this concept of CRS and HIPEC gives good results. You can see that on the survival curve, overall and progression-free survival going out up to 20 years or over 50%. The problem is they're very long procedures, long hospital stay, post-op mortality about 2%, and a major morbidity. 1 in 4 patients have major life-threatening morbidity. And the question is whether CRS and HIPEC could work for more common problems such as colorectal cancer. And the French have published a multi-center series a couple of years ago, 2009, in which they published on 1,290 patients, 523 had colorectal carcinomatosis, they called it at the time. I hope you can see that, but as in most survival curves for peritoneal malignancy surgery, pseudomyxoma is right at the top, gastric cancer is at the bottom, and colorectal peritoneal metastases are somewhere in the middle. We've already heard a little bit about liver metastasis, the commonest site for metastasis from a colorectal cancer. And of course, we have lung metastasis. And the peritoneum is the site in 10 to 15% of patients with metastatic disease. And the problem for peritoneal metastasis is these patients do much worse. This is a Dutch registry, and you can see the bottom line is patients who had peritoneal metastases, and the top line is other metastases, lung, liver. This is all patients resectable, not resectable. Lung, liver, solid organ metastases do much better than peritoneal metastases. This is from a combination of factors, maybe the biology, but also these patients get obstructed, they can't tolerate systemic chemotherapy and so on. So it's bad news for patients with colorectal peritoneal metastases. It's said to be about 10% at initial diagnosis. We get the feeling it's going to go up with coronavirus because I think people have delayed presentation and so on. And the other interesting thing is that after surgery, approximately 25% of patients with recurrent disease have peritoneal disease. And for about 1 in 3 of those patients, the only recurrence is peritoneal, no liver, no lung metastasis, just peritoneal recurrence, which of course is very difficult to manage. Of course, there are patients, and we didn't mention that there are patients who have lung, liver, and peritoneal, and the whole complexity becomes really difficult to manage for the patients and indeed for the medical care teams. The problem with colorectal peritoneal metastasis, it can vary from on the left side where you have 2 little tiny nodules to the right side where you have carcinomatosis and there are almost no surgical options. And of course, we should always try and pick the winners. And what will determine the patient outcomes? Well, there are 2 big factors that are almost self-evident. The first one is the completeness of site reduction. Same as Fernando alluded to in liver disease, you have to resect all the tumor if at all possible. And we have a completeness of site reduction scoring system, which we use when we've operated on patients. And of course, there's the extent of peritoneal disease, the PCI score. The CC scoring system is that you should be achieving CC0, no residual disease, or disease less than 0.25 centimeters, 2.5 millimeters. The reason being that at this level, hypothermic intraperitoneal chemotherapy can penetrate nodules up to about 3 millimeters. And so the 523 French cases reported in 2009 or so, you can see if there was no residual disease, CC0, the median survival is 2.5 years in this experience. And if you look at the other end of the scale, the median survival, if you have more than 2.5 millimeter residual tumor, is less than 6 months. So you probably do a lot of harm to these patients and very little benefit. The PCI scoring system was designed by Paul Sugarbaker and his fellow. And what it does is it divides the abdominal cavity into 9 regions and 4 regions for the small bowel. The small bowel is critical in this disease. If you have a lot of small bowel involvement, then it's very hard to do anything good for these patients. And the lesion size goes from 0 to 3. And so you have 13 regions and you have 0 to 3. So you can have a PCI of 0 to 39. Clearly for pseudomyxoma, you can have a very high PCI and still have a good outcome, a good surgical resection. But for colorectal cancer, it's completely different. And so it's well established, and this again is using the old series of 523 patients, PCI less than 6, the blue bar, there's a median survival of over 3 years. If it's greater than 19, you can see it's just over 1.5 years. And of course, it's common sense, a better survival with low volume disease, better survival with complete site reduction. And we have a major problem, I think, much more so than Fernando has in liver metastasis or lung metastasis or even locally advanced primary cancers, as Ian talks about, is that we have a potential for cure, but it's not great, maybe 20, 30%, even if we achieve complete site reduction. But we have a lot of complications, and we have some very serious complications and some mortality. And so what we've tried to do over the last 10 years or so is to work a little bit on the terminology. And so what we've said, Tom Sesser, who's my colleague, and I said that we are really talking about resectable colorectal peritoneal metastasis. We're not talking about carcinomatosis. And we really have to select the patients, and you have to have a lot of experience to do these rather crazy operations. You should be trying to remove the tumor completely. And in our opinion, you should be using hypothermic intraperitoneal chemotherapy. Case selection is a real problem for us, and it's difficult for us to be sure who exactly is going to benefit from the approach of CRS and HIPEC. What we said a couple of years ago was that patients present with synchronous peritoneal metastases. You can quite often predict this, that's CT, MRI, and so on. And in those patients, it might be worth considering a diagnostic laparoscopy and possibly referring to a specialist unit. It's much easier to do CRS and HIPEC in a patient who hasn't had extensive previous surgery. Initially, we all thought that these patients would do best, but actually the biology of the disease means they don't do as well as you would expect, because it's quite easy to do complete cell reduction on many of them, but the biology is probably not very good. Majority of patients that you will all see and that we see are metachronous peritoneal metastases, 6, 12 months down the line, several years down the line. And this is where the problems arise, because CT, PET-CT, MRI, anything we try is very poor at actually determining that the disease is localized. Laparoscopy is helpful, although it's difficult if you've had complex primary surgery, but I think increasingly for patients who have had laparoscopic surgery, it's much easier to do a diagnostic laparoscopy in these people, but it probably should be done in a unit who actually is going to undertake the CRS and HIPEC. Of course, we've already mentioned this, the best outcomes, limited disease. We used to think synchronous at the same time, although the biology is probably worse. And favorable biology is if you have somebody with localized disease 3, 4, 5 years after the primary, then that's probably favorable biology. What really determines the outcome, of course, is complete tumor removal. As I said, we have real problems with imaging. This is a 2009 paper in radiology, but to be quite honest, it hasn't moved on very much since. A tumor nodule less than 0.5 centimeters, maybe some radiologists will be picking up tumors of 2, 3, 4, 5 millimeters, but actually, whatever you use, it's very hard to detect this low volume disease. Of course, the bigger nodule is much easier to see on any imaging modality. And there is no technology whatsoever that can see this. This is a patient having a diagnostic laparoscopy, and there is no imaging modality at the moment that will pick up these resectable colorectal peritoneal metastases. And what we say is that you should focus on this cartoon if you are at laparotomy or laparoscopy or even at imaging. You look under the diaphragm, you look in the pelvis, and you look in the omentum. These are where these nodules will be. There have been 3 interesting recent trials around cytoreductive surgery and HIPEC, one in ovarian cancer in 2018 and 2 on colorectal peritoneal metastases. The very nice study by Wilhelmina van Driel from Holland showed that if you take ladies with ovarian cancer, and if you either do complete cytoreductive surgery or complete cytoreductive surgery plus HIPEC, the HIPEC, oxaliplatin or platinum-based HIPEC, improves the outcome in those patients. So it appears to suggest that appropriate HIPEC will work well. The French multi-center ProFellowship study was a study whereby patients at high risk of developing colorectal peritoneal metastasis, in other words, patients who had had ovarian metastasis, who had had resected peritoneal disease, and then went on to have systemic chemotherapy, normal imaging, normal tumor markers, and they were randomized into second look surgery or continuing surveillance. And what you can see is that 150 patients, the actual survival curves completely overlap. So no real benefit from doing a second look CRS and HIPEC. What was very interesting, and I reviewed this paper and did an editorial, was that despite state-of-the-art normal imaging, 52% who had a second look laparotomy, 37 out of 71, had peritoneal disease reported by the surgeon. And in 4 patients, this was not resectable, low volume extensive disease. What was also interesting, and we all get caught out here every now and again, is that of 11 of those 37 patients did not have peritoneal metastasis when the pathologist reported the results. This was fibrotic tissue, presumably chemotherapy downstaging, scar tissue, etc. So it is very difficult sometimes to be absolutely sure, even at surgery, what is a metastasis and what is not a metastasis. The one that everybody talks about and has created chaos all over the world is the Prodigy 7 trial. And this was a trial of about 260 patients who were randomized to cytoreductive surgery alone or cytoreductive surgery and oxaliplatin-based chemotherapy. And again, you can see the survival curves completely overlap. There is no difference in using oxaliplatin HIPEC. Of course, the problem with the oxaliplatin HIPEC was it increased the morbidity and the complications. And there's been a huge backlash all over the world against HIPEC because of this one randomized controlled trial. You could summarize these very good trials by looking at, in ovarian cancer, HIPEC works if it's the right drug. It's a platinum-based sensitive ovarian chemotherapy. What ProFellowship has showed us is that imaging is completely useless for low volume peritoneal disease. And Prodigy 7 shows us that oxaliplatin HIPEC is useless, but actually doesn't mean that other forms of HIPEC might not work, such as good old-fashioned mitomycin C. We are often accused of over-treating these patients, and I think in some cases we do, and a bit like the ProFellowship trial, we have treated patients with CRS and HIPEC, taking out lumps of tissue we thought were tumor, come back as fibrous tissue. So we do overtreat patients. What Prodigy 7 has shown us, which is really, really important, is that the median survival in both arms of the trial, CRS alone or CRS and HIPEC, was 42 months. And this is the best results ever reported for a surgical approach to peritoneal metastasis from colorectal cancer. Selecting patients is very difficult for us, for you, for everybody. These patients have to be fit and well. I mean, it's not like Fernando's patients who have successful liver resection and they can go home in a day or so. These patients have to be fit and well to undergo this surgery. And we do a lot of so-called collateral damage because of the adhesions, bowel injuries, and so on. And the type and the biology of the disease is very important. So the time to recurrence, if somebody recurs within 3 months, 6 months, then it's likely that we can't really help those patients. And signet ring cells are really bad, poorly differentiated. So in summary, cytoreductive surgery works for colorectal peritoneal metastasis. There's a whole language around peritoneal malignancy, which is quite useful, we think. The redistribution phenomenon, that little cartoon is very helpful. Radiology, laparoscopy, laparotomy, this is where you find these nodules. And I think that we continue to explore that perhaps we need to look at different hypothalamic intraperitoneal chemotherapy agents, in particular mitomycin C, which is what we've always used. Thank you very much for your time and attention.
Thank you very much, Brendan, for your presentation. We're running out of time a little bit, but we've decided to take some time for questions anyway, because we have the experts here now. So if you want to ask questions, please post them in the Q&A section. I'm going to start with a question for Brendan. If colorectal surgeons, when he's doing the primary resection, finds a limited amount of peritoneal deposits, should he stop and refer it to a HIPEC center, or should he just do the primary resection first and refer later on? What's your preference?
I think the evidence suggests now, especially from a fellowship randomized controlled trial, that if you have limited disease and you can safely resect it, then you should resect it. And that's why I think it's becoming obvious. It's very difficult. So sometimes you get a phone call from somebody who has maybe divided the bowel, and they say, we've got a bit of peritoneal disease, what are we going to do now? So I think the evidence suggests that if you find localized peritoneal disease, then you should resect it. And patients would generally go on systemic chemotherapy when they recover from their procedure, and then monitor, because Profilachip says even those patients, there seems to be no benefit from going back in at 6, you're going back in and trying to do CRS and HIPEC, which is quite fascinating. It's great for us because we were getting a lot of these patients, they're higher risk of developing. But I think the message is coming across, I think for all surgery, removing the tumor completely is really important. And what I think is really important is to try and focus where these tumors are, greater omentum pelvis under the diaphragm, and then you might find them and you may as well remove them.
Okay,
I think this is a key message for everyone outside. So we as surgeons, we have those big impact on what the surgeon's life is going on. And you showed that brilliant 42 months, and this was the best result for people some years ago, which would end up maybe after 6 months. So this is a big message. Thanks really, Brendan, for that good talk.
Yeah, thank you very much. I actually have the same question for Fernando, because I expect the answer to be completely opposite. What if a colorectal surgeon finds a solitary liver metastasis easy in segment 3? He can chop it off with the ligature anyway. What do you think? Should he combine that without being a liver surgeon, or should he stop and reconsider, do the primary resection and do extra diagnostics for the liver? What is your opinion? Please open the microphone because we can't hear you. Thank you.
Okay, great. Thank you. So the question is an unexpected liver metastasis, right?
Yeah.
Okay. Well, if you have endoscopic ultrasound available, I think you should do an endoscopic ultrasound of the liver. And if it is really a solitary liver metastasis, you should resect it. But if you don't have an endoscopic ultrasound, I wouldn't do any resection, because you don't know if there are many other lesions or not. And I think you should do, well, it also depends on the kind of studies that you had previously. If they were quality studies, you had an MRI of the liver or a CT scan, and this is a very small liver metastasis that couldn't be recognized in the CT scan, well, I agree that you should resect it. But if the quality of the preoperative imaging study is not too good, and you are not sure if there are any other lesions or not, and you don't have an ultrasound available, I think we shouldn't do a resection that you don't know if it is going to be radical or not.
I agree. Thank you very much. Walter, do you have other questions?
Well, actually, I would point out two things that came up in the lectures of Fernando and also from Brandon. I think should be pointed out a little bit more. The one was Fernando telling about the team with the anesthesiologist. And I think the same is true for Ian as he talked about the exenterations. So this is very important to keep a close contact, to reduce the central vein pressure. That makes the big difference. And also have the steps, like you said, always have the Pringle. If you go for exenteration, you must be aware there are big vessels if they had radiation before, so you will run in a severe problem if you not know what to do. So maybe you need a vascular surgeon, you need options to stop that bleeding or avoid that bleeding, which even would be better. And you pointed out, Fernando, that this relates to the overall survival. This was like DME and CME came up in colorectal surgery, and we are not aware as this is true also in the liver surgery. But what you proved now, and you pointed out, if you make a proper resection without blood loss, overall survival, disease-free survival will be much better. So we should be aware as surgeons. And the other thing I think is important, what Brandon mentioned, is that if you have a case, you have to look after dead dots. And you have to bring it in the OR report, because sometimes I think if I look on younger, they focus, well, there's the tumor, my job is to resect the tumor, and they forget to have an overview and to have a look where could be those dots, and they bring it in the OR report and they take a biopsy, even if it's fibrotic in the end. Well, that's nice if it's fibrotic, that's the best which could happen. But always have a good overview, what it's intra-abdominal, because what we really see on the CT and on the PET and on the MRI is always larger than 5 millimeters. All those which are a little bit smaller than 5 millimeters, we will not find them out. But in laparoscopy, in open surgery, we can see them, we can feel them, and we should look for them. I think that this would major point you made in your lectures.
Okay, well, I don't see any other questions in the Q&A section.
Well, there was one regarding people from for example, African countries as surgeons in Europe, and as you presented, this is high-end surgery, what everybody is doing. And people were asking, how can we join that? So how do we bring this high-end surgery also to like African countries, that surgery could be done there, or people could be educated to come to Europe? So this is a question for the whole faculty. Your ideas, how can people from Nairobi, for example, join this group?
Can I comment on that? I mean, I think it's a really important topic. I mean, I think one of the reasons I came to work in Beijing, so I can work with Bill Heel, was that surgical technique is really important. And I think Fernando alluded, of course, technology is getting better, but we can do a lot still with our hands. But you do need a team, you do need anesthetics, so you're right. But I think focusing on surgical technique is primary issue. And that's why CME, it was open surgery. Okay, robots will help us. I think they're fantastic, but we can still do a lot with open surgery. So I don't think we should be despairing. I mean, we don't use any robots in our reductive surgery and never will probably. But I think while you're absolutely right, if you try and do very major operations and you haven't got good anesthetic and nursing care, then it won't work. But I think we can help surgeons to develop their skills. And that's really important. And technology helps, available technology, and hopefully affordable technology will develop.
A couple of comments in a similar way. But first, I think that internet and the possibility and laparoscopy, them together, has changed the way we learn and the way we teach surgery, not only liver surgery, but in my specialty very particularly. It was very difficult in open surgery to learn because, well, it was difficult to record, even to assist to a procedure. It was like gazing from behind the surgeon. And now with laparoscopy, you could see exactly what is going on, and it's recorded and it's available on the internet. And these educational activities are very, very useful. And I've learned many procedures just watching tutorials or videos, and they are like a treasure map. Of course, experience matters, but these possibilities to revise once and once again, like these webinars, a procedure, and how the tips and tricks are very, very useful. And internet is great, fantastic for this. And the second is the possibility of proctoring, or even distant proctoring. We are doing some kind of proctoring with liver units, and they send us the case. We discuss by telephone, and we exchange opinions on how to approach that lesion, and it really works. And we can proctor and see how they progress little by little. So I think there are many good opportunities. They are not necessarily presential.
Thank you very much. Walter, do you want to add still something? Or was this?
Well, I think that's absolutely these steps you can do, and also you can go for courses. So we offer courses in Europe, and there are also courses, of course, close maybe to your country, giving hands-on and lectures. So it's a combined thing, because only learning from the internet, it's a little bit too less, but it's important, and you can have a look at it, and you can contact and go for those hospitals who do that in a caseload which is high. So this is also part of the webinar. We try to build in some hands-on training courses also for participants.
Yeah. And this was also a little bit the idea of this webinar series. We started relatively easy with basic techniques. We progressed a little bit more. And you already stated the Davos course with the basic skills we can train. So there are not enough options for surgeons abroad to get training. And I think there are a lot of places where they can also do clinical experience as well. Okay, so I want to thank everybody for their patience and for their time. And we are going to stop this webinar. And thank you very much again. Thank you.